Welcome all, and once again, this is to part B of the fifth edition, edition and accreditation. This part B, we call this the digging deeper. Today, I'm going to talk about the core module accordingly, and that's what we'll be looking at today. What we're going to do now is that we just move the slide along. We would like to, the Northern Queensland PHN and AGPAL acknowledges the Aboriginal and Torres Strait Islanders peoples as Australia's First Nations peoples and the traditional custodians of the land. We respect their continued connection to the land and the sea and country, their kin and their community. We also pay respect to our elders past, present and emerging as the custodians of knowledge and law. I'm just looking at the names on the participants list, and thank you for coming back. I don't really need to introduce myself accordingly, because most of you would be aware of me from last week in relation to this. But I suppose that the thing that I want to put across to you all is that, as I said, I've been a surveyor for 22 years, and I'm a practice manager, and so I struggle. As I said, a 12-doctor practice at the foot of the Blue Mountains, and I, like you, struggle in relation to the accreditation process as well. So I know what you all go through in relation to the accreditation process. And being a surveyor, what I can do for you is to give you some of those tips around how you can better prepare yourself for the accreditation process within your practice. This is a series called High Performing Primary Care Series, which and this is supported and funded by the Northern Queensland Primary Health Network through the Australian Government's PHN program, and for them we are truly grateful for being able to do this. And as we said last week, this is part 2 of section 2 of the overall series that the PHN has been putting together. As I said, you've had continuous quality improvement and the practice incentive payment quality improvement program, and now we move on to the standards. And I hope you've registered for 3 and 4, population health and digital literacy, and of course the last one, integrated care, which is very critical for us in relation to what healthcare looks like for the future. And part of the 5th edition standards is all around team-based care and integrated care. So series number 4 in this, part 4 of this series, links in with part 2 in relation to the college standards, because as I said, part of the college standards is around integrated care and how does that look. When we look at this high performing primary care series that have been put together and which you're a part of, there are a whole range of different types of education and training that the PHN is providing, and they're going to focus on a whole range of areas. And I suppose that the second last one I think is important is implementing sustainable primary care. And part of the accreditation process is really about sustainable primary care in relation to the accreditation process, and also the last point about promoting integrated care in the region. And the 5th edition standards, as I said just a moment ago, promotes integrated care because it's all about the team. I keep saying that because historically, when we first started off in our accreditation, I know in my practice, I did everything. And as time has gone on, I realise now that I can't, because there's actually a whole team approach. The standards have been rewritten to reflect everyone within the standards. So this is, as I said, this is webinar B. This is the second of 3 within the college standards presentation, which we're going to look at. When we look at the college standards, this particular series which has been put together, we're going to talk more about, last presentation we talked about the changes between the 4th and the 5th edition. We discussed in the last presentation about the intent of the indicators in the 5th edition. What did that mean? And we also looked at, started to look at some methodology around how to identify areas in our practice that we don't meet the standards accordingly, the 5th edition. And then we're also going to have a look at aspirational, which we did, aspirational and mandatory indicators, and what do they mean? Because terminology's changed between the 4th and the 5th. And then the last one we touched on is different ways of evidence that we could provide to surveyors to support the intent of the indicator accordingly. Now, if you were on the previous presentation, there was some key information which came out of that. And what I'd like you to do, if you could sort of either come off mute or put in the chat box what may be some of the answer to some of these questions which I'd like to pose to you. There were 3 key words which came out of presentation A. 3 key words. Can you remember what those key words were? Because they are the basis by which of how we assess our indicators. So 3 key words. If anyone can remember one of them or 2 of them, that would be great. So if you could put that in the chat room, and we've got someone monitoring the chat room, or failing that, very good, Tanya. Intent is the first one, and that's really important, the intent. So thanks very much for that, Tanya. The thing about the intent, just because you may meet the indicator, does not necessarily that you'll meet the standard, because is the intent correct? Remember we spoke about the email policy accordingly, that although we had a policy, but was the intent right at that point in time? And the answer was no. And as you're aware, I marked that particular practice not meeting that indicator. Anyone else? What maybe there was 2 others? There is the intent, and that's the big part of last week. So that's word number 1. Anyone else got any other words? Lisa, yes, there were 2 other words which we used, was mandatory and aspirational, because we now realize that mandatory is by that blocked arrow pointing to the right. Mandatory means we must meet that particular indicator to meet the standard. And the aspirational ones are not mandatory, and they're the things that the college have actually said to us we need to start to think about in relation to how we can, part of that CQI process is aspirational and mandatory. Yeah, 2 other words, 2 other keywords. So there was the intent, and anyone got the other 2, what the other 2 may be? They're part of the mandatory, and these 2 words were coulds and musts. So the coulds, the musts, and the intent were 3 keywords in relation to part A. Then we looked at, which Lisa, you stole my next question, is in relation to what does mandatory and aspirational mean? I just touched on those. Another question I want to ask you, there are 3 modules in the redesign and the structure of the college standards. Anyone know what those what the 3 modules are called? Sorry, thanks very much, Tanya. Yes, the could, the intent, and the must. Thanks, Tanya, for that. 3 modules, and we're going to touch on the 3 modules in more detail in part B and part C accordingly. Yes, the core module, and we'll be looking at the core module today. So that's the first one, the core module. Thanks, Lisa. Anyone else? Has anyone else got any, the GP module? Yes, so the core module, GP module, and the QI module, the quality improvement module. The next question I want to ask you is a really important one, and this is the whole philosophical change in relation to substantiation of meeting the indicator. So who does the burden of proof lie with now in relation to meeting the indicator accordingly? Who does the burden of proof lie with? It's different to what it was before. So who has the responsibility now to indicate to the surveyor in relation to substantiation? The practice is correct, Tanya. The burden of proof now, as we said in number 1, sorry, presentation 1, the burden of proof now lies with the practice, not with the surveyor. And the surveyor's role is to ensure that the information which you provide will actually will suit the indicator accordingly. Now, there was the main reason why that this burden of proof will change is because every practice is different. Every practice is different, meaning that the evidence provided for, say, maybe Aboriginal Medical Service may be different for a corporate practice or a solo GP. So in the 4th edition, the evidence was quite prescriptive. You must have, you must have, you must have. In the 5th edition, is that you are to provide evidence to suit your practice accordingly. Now, as we saw last week, that the evidence which you may have had for the 4th edition may be the same for the 5th edition, as what we said about the practice information sheet. In the 4th edition, we said effectively you had to have a practice information sheet. In the 5th edition, that's not the case, as long as the patient is aware of certain components of your practice. But some people, practice, are still using the practice information sheet, and that's fine. So thanks very much for that feedback in relation to some of those questions in reflection of our presentation last week. So part B today, we are going to talk about the core module. We're going to talk a little bit of a discussion around some policies and procedures, and we're going to talk about interpreter and other communication services. Then we're going to have a discussion around determining the intent of that particular criterion, C1.4. We're going to look about costs associated with initiated care by the practice. That's one we have to start to think about. Culturally appropriate care, and then we're going to talk about business operations systems. Then we'll go for a break around the 10 o'clock mark your time. Then when we come back, there's a series of policies which we're going to work through accordingly from there. So that's the sort of the program for the next 2 hours accordingly. When we look at the 5th edition, as we said before, and thanks Tanya for showing, preempting this particular slide, the college standards are broken up of the core, quality improvement, and the general practice module. And today we are going to be looking at the core. Now, what I'd like to do is that I would like you to, as a bit of an activity accordingly, and I'd like you to all input, if you could, to this in relation to the chat room. The learning activity we want to talk about now is in relation to our infection control policy. It's called GP 4.1b. So just think about GP 4.1b, and it's about an infection control policy. What do you think should form part of an infection control policy? What are the parts that form in relation to an infection control policy? When you're putting an infection control policy together, what should be included in the policy or the procedure? Can you just put some random thoughts down in the chat box? You may come up with one idea, or you might come up with 5 ideas. So what should be in a policy and procedure for infection control policy within your practice? Remember last week we spoke about prescriptive evidence, and prescriptive evidence is evidence you must provide, and GP 4.1b is prescriptive evidence. You need to provide an infection control policy. Yes, there's some. We're talking about standard precautions in relation. Very good. We are also talking about infection controls standards. May link into it. Cleaning, yes, environmental cleaning is a good one. Hand washing is another one that we should put into our policy and procedures in relation to infection control policies. Thanks very much for that. And what I'm going to do now, I'm just going to show you what may be some of the things that should be in your policy and procedures manual on infection control. So it's GP 4.1, notice that arrow to the right, so it's mandatory. B, our practice has a written specific policy that outlines our infection control processes. That's the indicator, you know, and it is mandatory. So what are some of the things that should be involved in the in that policy? Now, some of the things that are mentioned on the chat line are definitely in there. But a big one for us, I think, is the last dot point as a result of COVID is PPE. Just make sure that PPE is addressed in your specific policy or infection control. If it's not, you know, a surveyor will look at this and say, well, how critical is it? Has the intent been met, or is it an OFI accordingly? So what we're looking at now is they're the sort of things that are required in the policy. Now, if you go to the AGPAL registry of resources, if you're an AGPAL client, you'll find a sample policy procedure there in relation to 4.1b and then customised. Remember that I said last week, please ensure that if you use any policy and procedures, that they are customised to suit your practice. As a surveyor, do you think if you put together a policy and procedure around infection control and it is not customised to suit your practice, do you think the intent has been met? As a surveyor, I would say no. Now, thank you very much, Tanya, for that feedback. You are right. The intent would not be met. So any templates which you use, ensure at least put your practice's name in it. Remember I said last week is that what a surveyor does is they're to validate that what you say you're doing is actually you actually doing it. And we do this a number of ways. We do it by looking, we do it by listening, and we look at by documents, and we do it by talking. So we validate what you say by a number of methods accordingly. So validation is important. Make sure your policy and procedures and templates are customized to suit the way in which you do things. So when we look at the core modules, as you can see them on the screen here, there are 8 standards in the core modules. The first one is communication and patient participation, rights and needs of patients, practice governance and management. There's some new criteria in that. Health and promotion, clinical management, information management, and health records, and education and training of non-clinical staff. So they're the 6 standards that make up the core standard accordingly. So core standard 1 has 5 in it. So when we're talking about core standard 1, this particular standard provides what's called timely and accurate communications that are patient-centered. So what we're going to do now, we're not going to cover the first 3 because we don't have the time to do that that we have in this presentation accordingly. What we need to think about now is we're now going to look at criterion C 1.4 and criterion C 1.5. And C 1.4 is about interpreter and other communication services. And C 1.5 is costs associated with care initiated by the practice. Now, if you need any support in relation to 1.1 to 1.3 in this, have a chat to the PHN, Tanya, or give your CLO a call at AGPAL, and they'll take you through what may be required to meet those indicators. But I cannot stress enough the importance of explanatory notes. If I could say, read my lips, read my lips. The explanatory notes in the standards are excellent. And they actually really tell you what you need to have to validate the intent of the respective indicator. If you're an AGPAL client, you have access to Accreditation Pro. If you hover over the respective criterion, it'll pop up on the screen and tells you effectively what may be evidence you may need to meet the criterion. So 1.1, 1.2, 1.3, we're not going to address, but 1.4, etc., and 1.5 we will. Righto. Now let's have a look at C 1.4, which is interpreter and other communication services. Now, in the 4th edition, there was some requirements around communication with patients, but the key ideas from the explanatory notes, and this is what's come from the explanatory notes. Why is this particular criteria important? Now, we need to understand that a patient has the right to understand what is happening, and they need to participate in their care. Remember I said before, the 5th edition is all around about the team, and the patient is part of the team. 5th edition is the 5th edition is all about the patient and their involvement in their particular health as well. The practitioner has a professional obligation to ensure effective communication. So they're the key ideas. Why is this important? These are the ones which have come from the college standards accordingly. Please look at the explanation mark. So what do you need to do to meet this criterion? Well, implications. You need to consider your patient's population and make sure you have access to resources. Now, this is the important bit here. A surveyor will look at your demographics to ensure whether you have a high population of non-English speaking patients. And then we look at what sort of information you are going to have to support languages other than English. So when we think about this, what may be some of those things you may need to put at? Now, there's a requirement. You need to consider the needs of your patients who require assistance due to hearing, speech or vision impairment, etc. So when we look at this whole component of interpreter and other communication services, do you think that you can come up with some suggestions on what may be some evidence that you would require in relation to substantiate this particular indicator, C1.4? So has anyone got any thoughts or suggestions in relation to what may be some evidence that you may require to meet this particular indicator? Any ideas? What may be? What may be? Signs in the practice. Thanks, Lisa. This is a very good one. Signs in the practice. It's interesting about signage. We talk about policies and procedures. There's informed consent fact sheets. That's another good one, Tanya, in relation to interpretation. Utilising the TIS is another example. You may need to show the surveyor your login details and your email details. You may want to show the surveyor, a consultation where it had been used, a TIS has been used, yes. Some practices use the hearing, say we've got a hearing loop. Who would have thought of a hearing loop as part of evidence for C1.4? Yes, a hearing loop you could use in relation to this. So start to think outside the box on this and say, well, how can I, what do I need to put into the practice accordingly in regards to evidence to support? So here is the indicator C1.4C, interpreter and other communication service. Our patient can access resources that are culturally appropriate, translated or in plain English. So naturally, in this particular case, an Aboriginal Medical Service, AMS, will actually have translations into their local, the local dialect accordingly, the local language. As you know, I do quite a bit up in the Arnhem Land in relation to AMSs up there and accreditation, they have their own brochures in their own local language and dialect. They have interpreters within the practice as well to assist. So it's important that that the evidence which you show relate to your patient cohort. It's important if you look at that when you look at this particular criterion, C1.4, that if there's any documentation you have in clinical notes, this is always good to utilise as evidence accordingly. So A, you may have a policy written. B, you may have brochures written in different languages. You may have signage up. You may have, in my case, you may have brochures on your website as well. You may have access to the translation service, and there may be documentation that you may have in your particular clinical notes as well. But once again, the important thing is that you can actually now see that you can determine the intent, whether you meet the intent or not by the information which you provide. Remember, I said before, just be mindful that you don't providing information, too much information, to substantiate accordingly. Righto, now we've had a look at C1.4. Now let's have a look at let's have a look at C1.5. C1.5 is about costs associated with care initiated by the practice. This becomes a challenge for some practices, only because some practitioners turn around and say, well, why do I need to know, why do I need to keep information about what specialists charge, etc. It's not really about this. In the explanation notes, it says that providing this information is one way you can help patients make informed decisions about their health. The cost may be a barrier to undertaking the referral process. It may be an indicator on this. This is about trying to ascertain whether there's going to be a barrier to the person's continuing health. Is it because that particular specialist is privately billed private hospital? Or is that patient, that practice, that specialist bulk bills from his room for a pension and healthcare card? So you're not talking dollar values in this. This is about around the fact of how can we provide information to our patients. Now, interesting about this, how do you bring this to the notification of your patients in relation to substantiation accordingly? And we'll talk a little bit more what may be some of the evidence which you require. The guidance about this is that there are two components to this particular criterion. First part is about cost at your practice, and B, cost for referred services. So when we're looking at this criterion C.1.5, A, think about your practice and think about the referral component. And we'll talk in a moment about what may be the evidence you required to meet the intent of the practice for these. So let's look at this in a little more detail. Our patients are informed about out-of-pocket costs for healthcare they receive at our practice. So this is C1.5 mandatory A. You must inform patients if there are out-of-pocket costs for healthcare they receive at your practice. This is an essential mandatory requirement accordingly. So when you're looking at C1.5A, let's talk about what may be the evidence which you're going to require to substantiate this. Out-of-pocket costs at your practice. Even if you bulk bill, your fees and charges still need to be displayed or provided. Now, can someone sort of put in the chat room what may be some of the evidence accordingly on this? Have you got any idea of how you would meet this particular indicator or the intent of this indicator? You must inform patients if there are out-of-pocket costs for healthcare they receive at your practice. Yes, Nicolette, you're correct. And Lisa, signage. The signage could be at the front desk. It could be on your website. It could be in your practice information sheet. New patient bookings are told. New patients told on booking. Well done, Michelle. Yes, it could be part of your new patient booking process. Every one of these, I think, is very important. That you actually may have a policy written about this. So if you've got a policy on C1.5 mandatory A, that would be good. That could be part of evidence. That could be part of the evidence which you require is by a policy. So very good. Signage, website, new patients on booking. They are all very, very good suggestions for meeting the intent. Now, from my side as a surveyor, if I see these documents around, sign up, front desk, practice information sheet, a website, all of a sudden that would be a net indicator for me because I can actually see those things, and I can hear those things. I can hear Michelle talking on the phone to patients. So that's why a surveyor's role is just not talking to people, but it's a listening process. So well done in relation to providing that feedback there. Now let's have a look at out-of-pocket expenses for healthcare they receive at your practice. let's talk about now the out-of-pocket implications for referrals. Advise patients when they could be out-of-pocket costs associated with attending a referral. That could be diagnostic imaging or diagnostic for bloods or for a specialist. You notice the you do not have to provide the actual cost. You refer them to the service provider to find out details. Now, my referrals to specialists on the bottom say to the patient, please contact the specialist for what costs may be associated with this particular service. We may give the phone number to the patient to say you need to contact the specialist to find out what the costs may be when you make the appointment. If you make the appointment for the patient, and some practices do that, you can then tell the patient, oh, look, there'll be, they've indicated it's a $240 fee up front. You do not have to know. You need to be able to refer patients to where that may be. And in my particular case, as I said, it's on my referrals, or the doctors say, or the nurses say, well, you may need to contact the specialist to find out what the costs may be on that. Has anyone else got any other suggestions how this may be met, this particular one? Any other new and thoughts in relation to, I saw a practice once that actually had a sign up at the front desk for all referrals. It's your responsibility to contact the specialist to find out the costs associated with this service. This one, C1.5A, these are out-of-pocket expenses in relation to the referral process to someone else. Remember, it could be diagnostic imaging, it could be pathology, or it could be to a specialist. So there we have C1.5, costs associated with initiated care on the practice. Now, has anyone got any questions in relation to those two particular criteria and indicators? Are you okay in relation to the policy on infection control, interpreter service and communication, and also with the out-of-pocket costs accordingly? No one's got any questions on that? We'll move on now. So that is that's core 1, communication and the patient participation core standard 1 that we're only going to address today on those. But remember, any clarification on criterions 1.1 to 1.3, have a chat to Tanya and also or your CLO that can help you on that. But I keep coming back. Don't forget to read the explanatory notes because they are most important indeed. We've done C1.1. We are now going to have a look at standard core 2, rights and needs of patients. That's what we're going to look at now. The rights and needs of patients. In the rights and needs of patients, the purpose of this particular core standard is the practice respects the rights and needs of patients. And we remember once again, we spoke about the whole of team approach, patient-centered care, integrated care are a massive part of the 5th edition. So there are 3 criteria in this: 2.1, culturally appropriate care; 2.2, presence of a third party during consultation. And don't forget this also incorporates medical students. And 2.3, accessibility of services. They are the 3 criteria in core standard 2. So let's have a look at criterion C 2.1, respectfully and culturally appropriate care. Key points for the explanatory note. And this is, once again, this is an important part of the criteria, and is to go back and read the explanatory notes. Every patient has a right to refuse advice, procedures, treatment, and referrals. If a patient refuses, of course, we have to ensure that that is documented somewhere, that the patient has refused that treatment. And it's not uncommon that that happens. You know, cancer patients, is an important one, where they don't want to have any more treatment. So once again, a patient has the right to refuse. If a practitioner decides to no longer treat a patient, and that's okay, they can do that because of a whole range of reasons. Once again, our medical records have to reflect that the doctor doesn't wish to continue for those reasons, and provide alternate care. But in relation to refuse, and the doctor says no more, we need to, as it says, manage the risk to your practice by documenting accordingly. Now, part of criterion is around ethical dilemmas. And we'll talk about ethical dilemmas in a moment, what we may need to do with this. There's a requirement in unethical dilemmas that you have a system to document situations and actions taken, and to keep records of discussions with medical defence organisations separate from patient health records. So here we have in C 2.1 some requirements here around ethical dilemmas. And what we'll do now, we'll expand a little bit further around, or we could talk a deeper dive into this whole component of ethical dilemmas. C 2.1 is mandatory. E, our clinical team considers ethical dilemmas. You notice the word that says considers, which is important. Now, some guidance to you around this. Firstly, you need to think about what is an ethical dilemma? What is an ethical dilemma? That Christmas gift worth $50, is that an ethical dilemma? Is an ethical dilemma around ending of life for a patient? It could be termination of pregnancy, or it could be ending of life. Ethical dilemma about that 105-year-old, do I give a driver's license to? So there are a number of ethical dilemmas that we may need to think about in our practice. So we need a policy around this in relation, what do you do in relation to managing ethical dilemmas? In my practice, for instance, we actually have a policy around ethical dilemmas and a process. Very similar to a complaints process or a grievance process, but it's around ethical dilemmas. We actually have it as a standard item on our staff meetings and our doctors' meetings. And any ethical dilemma which comes up, if it does, is documented, and there's an outcome as a result of that. That outcome then is circulated accordingly to everyone else in the practice. It then forms part of a policy or some guidance around ethical dilemmas. The college standards are not specific in relation to ethical dilemmas, what they may be. The practice determines what an ethical dilemma may be, what it looks like, and the outcome accordingly. So what we're looking for as intent, meet the intent of this. Remember, the burden of proof is upon you. It could be a policy. It could be on a standard item on the agenda for staff and doctors. It could be an action, or just could be notes made in a minute. Discussions in an ethical dilemma regarding Mrs. Jones, patient X around driver's license for 105 years old. They asked me to. This is a true story. My next door neighbour was 103 and wanted to get his driver's license, and he came to the practice here, and he failed the site view 3 times. Got quite upset about this, so he came in and saw me one night and said, "Gary, can you tell me the last 3 lines and I'll memorise them, so I'll know what they are, and my vision will be all okay." What a great ethical dilemma for me as the practice manager and my next door neighbour. So that was an ethical dilemma which we had to discuss. I put on the agenda, no patient's name. Well, how do we deal with patients who want to do shortcuts in relation to eye test or whatever it may be? So no names and ethical dilemmas. We're after a policy on an agenda or an action. But remember, it's important that the team considers ethical dilemmas. We're now going to talk about criterion C2.1, respectful and culturally appropriate. Now, this is where it differs from practice to practice on this. If you're an AMS, your culturally appropriate care may be different to my practice here at Penrith. Once again, it's shaped by the cultural background of the demographics of your particular practice accordingly. So what is respectful and culturally appropriate care? How a person's culture may inform their values and beliefs. This is a very good one. I've actually seen practices in relation to culturally appropriate care by their website reflecting, especially in the AMS space or area or in mainstream general practice in areas with high Indigenous populations, you know, where they actually have Aboriginal signage accordingly, brochures. So when we're talking about this one here, we need to think about what do I have in our practice accordingly to substantiate. It could be statements on our website. It could be, once again, we come back to information brochures. It could come back to translation services, etc. So there we have C1.1, communication accordingly. Now let's have a look at the rights and needs of patients. So we've done 2.1. We're not going to touch on 2.2 or 2.3, just as a result of time. So let's move on to criterion 3.1, business operations systems. And so these are some new components of this particular standard around business operations systems. And some of us struggle with some of these, and we'll touch on what may be some of these indicators that practices may struggle with, because there are some new indicators in this accordingly. Business operations and systems. Why is this important? It's important because the type of business which we run has a direct influence in relation to the service which we deliver. So planning and setting goals and evaluating ourselves against these goals is critical in relation to the quality of care which we deliver to our patients, as I just said. So there are certain components of criterion C3.1 that are new to us at this. It's up for us to start to think about is how do they now integrate? So there's some planning, there's some setting of goals, there's some business risk identification. We have to have a business register accordingly, and the need to develop systems, as I said, to reflect the quality of care which we deliver into our patients in a safe manner. And this is done by the systems which we operate under. So let's have a look a little bit in a deeper dive in relation to business operations systems. Indicator C3.1, mandatory. A, our practice plans and set goals aimed at improving our services. Now, remember in part A, I told you the story about that general practice in rural New South Wales with a doctor. His wife was his secretary, one room, etc., and he was retiring in 18 months' time, etc. And what his plan was 3 things listed on a whiteboard in the tea room of what he wanted to do. And as you will be aware, and you indicated at the last session, that I accepted that. Come to my practice, a 12-doctor practice, 9 owners, etc. Our goals and plans are a little bit more complicated accordingly. So when we're looking at this particular indicator, you have plans and set goals aimed at improving services. They could be set in a set of minutes. It could be on a whiteboard, depending upon the complexity of your practice, Or it could be like me, where I have I've set a set of goals, I have a set of strategies, I have a set of key performance indicators, I have a set of how we're going to do it, when we're going to do it, why we're going to do it, etc., etc. A lot more complicated for me, only because I've got a more of a complicated practice. But once again, I keep coming back to this philosophy of intent is about the complexity and size of your practice. As long as you have a plan and someone is looking at it, somewhere, sometime, somehow, you would meet the indicator here. For instance, my business plan is reviewed every 3 months at my owner's meeting. Where are we up to? We do it every 12 months. And when we go to our weekend away with all my staff and doctors, we have a strategic planning once every 12 months somewhere. It could be simple as you standing around the water cooler. It could be at a staff meeting. What are the 5 things we want to achieve this year? And remember, these 5 things may be simple things like putting your carpet down, a new scanner for the front desk, advertise for a new nurse. Simple things like that. You determine what your goals are at improving your service. Well, yes, a scanner improves your service by far. Update your scanner. The scanners that now can email, etc., etc. So that's improving our service. Here's an example that I have in relation to a business plan template. Now, AGPAL resources have developed a document for you that should be on our website in our register of resources. So this is an example of a business plan template just for my practice. My focus area, and I have 4 focus areas, and this is focus area number 1, clinical governance. Focus area number 2 is human resource management. Focus area number 3 is financial, etc., etc. So I have 4 focus areas. Strategic priority for clinical governance, design a clinical governance framework for the practice. Objectives, that's what I'm going to do, and who's going to do it? Well, I'm going to do it. So that's just an example of a business plan template that I use for substantiation of the intent accordingly. But that's my practice. Your practice may be different. Break it down to the extent as what's relevant for your complexity and style of practice. Business risk management and criterion C3.1. It's important once again to go back and have a look at the indicator in relation to this. This is about risk management. And this risk management may be medical risk management or maybe business risk management. It doesn't really matter accordingly. So what we've got, Michelle, just good point. Michelle made a comment, does it need a time frame? Well, you could preempt your goals like the business risk management we're going to talk about now. It may be, these are the goals for the next 12 months. These may be the goals for the next 5 years. In my particular case, because mine's complicated, I actually set timelines, 3 months for that to happen, 2 months for that to happen, 6 months for that to happen. Here are our 12-month goals, here are our 3-year goals. So yes, you can put some framework around it in time frame wise. It's not prescriptive. I'll go back and say once again, the standards are not prescriptive. If you go back and look at, excuse me, I'm going to go back to that slide, our practice plans and set goal aim at improving service. The indicator does not indicate that you have to put time frames around this. But for an effective plan, yes, it'd be good to say, I want to achieve these goals in the next 3 months or the next 12 months. Whether you do or not, that surveyor is not there to look whether you've achieved your goals or not. What the surveyor will be looking at is currency of your plan. If you set it 3 years ago, is it exactly the same? Have you done anything? What have you done in that 3-year period or 2-year period since the plan? If you've done nothing to substantiate this, if I see a plan that was done 6 months ago or 8 months ago? No, I'm not going to go looking any further. But if it was done 3 years ago and nothing's been done, yes, I will look accordingly. So business risk management is a new part of the standards. We need to look at what the managing complaints mean, business risk management. We must have a process in relation to how feedback and complaints are managed accordingly. And risks are not about just managing complaints, but all of us will have a complaints policy in place accordingly. So let's have a look at this a little bit in more detail to this. Our practice has a business risk management system that identifies risk, monitors risk, and mitigates risk. There's 3 components to this C3.1C. We need to think about business risk approach. And it's just not necessarily about clinical risk. This is about business risk, and clinical risk is part thereof. Now, have you got a business risk register? And this is important for surveyors. What are the risks? Have you identified what the risks are in your practice? That's the first thing. Have you got a system that identifies risks? Yes, and it could be, for instance, it is on your policy and procedure about identifying risk, monitoring risk, and mitigating risks. You may have then a risk register where the risks go on it. You may then have listed on your agenda for your meeting, say any risks, anyone identify any risks. It should form part of all your agendas, so staff can raise and, oh yes, there is a risk those cords in the treatment room coming from the ECG will trip over those, etc. Or some of the front desk will say, oh, we have a risk in relation to such and such. Or the principals may say we have a risk as in relation to as in 6 months' time we're not going to have registrars here. So what are these risks? You need to identify the risks, monitor the risks, and mitigate the risks accordingly. So, so same indicator, C3.1, our practice has a risk management system that identifies, monitors, and mitigates risk of practice. Here's a risk matrix. You may want to use this. I use this in my practice. I have a spreadsheet with all my risks registered. Who's it allocated to? I then look at the risk and say, is it low, medium, or high? And I then put that in there. If it's, I ascertain it by this. Is it very likely it's going to happen? Yes. Is it severe? Yes. So that's high. So I'd put that in my risk register as high, and then I'd put into place, what am I going to do to mitigate that particular risk? So this is an example of how you would identify a risk and mitigate the risks in the practice by using a risk matrix. And we've all used those accordingly. Righto. And there we have 3.1 completed. Core standard 3, we've done 3.1, business operational systems. We are now going to look at 3.2, accountability and responsibility. What part of the standards is about accountability by everyone in the practice, not just necessarily by our doctors. It's the team approach. And I think it's important that we need to start to think about, well, how do we measure accountability in this? And part of accountability is having clear lines of accountability and responsibility. It's a good part of governance and encourages what we call CQI. And so part of this particular criteria is about the importance of position description statements accordingly. And we need to monitor people's performance in relation to their role and provide ongoing education and training. And we're going to talk a little bit more about what may be the sort of evidence which you require. But the induction program plays a big part in this. This is a very, very important document for a number of indicators to substantiate the intent. So you can use the induction program as for a number of pieces of evidence accordingly from there. So when we're thinking about this whole component of accountability, think about position description statements. And when you're doing position description statements, really they have to be customized to suit the role. You know, you can have one nurse one reception one doctor one allied health one accordingly, but just not one to fit everyone, because everyone has varying roles accordingly. So position descriptions, as I've said, it's important somehow there's an acknowledgement of the position description statement accordingly. You must have staff members assigned to take responsibility for risk management, complaints resolution. So when we're looking at position description statements, we need to assign certain responsibilities to certain people. And they may be, and these are around things like cold chain management, risk management, and complaints resolution. So critical part of accountability in job descriptions is your job descriptions must indicate the person who's responsible for those three areas. Now, in my case, cold chain management responsibilities with my supervisory nurse. So in her job description, it'll have cold chain management. I'm responsible for risk management and complaints resolution process. So that's in my position description statement, or my document in relation to what reflects what I do here. So it's important that where it is indicated, that needs to be in the position description statement. Also, there is nothing specific in relation to performance, how performance management is to be managed within your practice. Performance monitoring. There's no set requirement, nothing prescriptive by the college. So you need to think about, how do I performance manage staff? You determine how that may be. Most practices do it by formal performance management. You know, you fill a form out, I fill a form out. We sit down and we talk about it, and yep, and off we go. Most practices do that. Some practices just have handwritten notes in staff files. You know, Gary and I had a discussion today, and we agreed on this, and I'm going to do this, and you're going to do that, and you sign that, and I sign this, and we're all happy. One of the things we're going to need to think about is that poor performance needs to be managed when poor performance takes place, not when there's annual performance appraisals take place. So managing poor performance is different to managing performance monitoring. So when we're thinking about this, we need to think about what documents do I have where discussions have taken place and there's actions being given and ongoing development needs have taken place. So you determine how you do that. There's no specific requirement in the college standards of how you do that. But what it says, you need to document the performance discussions that may take place. Now, part of this accountability in a new staff member, your induction program is the performance. I have an induction program for new staff members, even for registrars. And I use that as evidence of how I manage the performance of a new person, 1 month, 2 months, 3 months, etc. I'll use that document. I have a standard checklist of month 1, month 2, month 3. I use that as evidence. So what is your other evidence you may find other than having just a straight performance appraisal process? Which leads me to C3.2 mandatory B, where about performance indicators. You notice what it says here, guidance to you. Each team member can be informal. Does not need to be informal, accordingly. But have a read of the explanatory notes that give you some guidance in what you may need to do here. But once again, it needs to be documented in one form or another. Some practices, as I said, go to the 360, the C3, the 360. but in my case, I just make notes on their files, which they agree to, and I agree to where to from here. If no actions required, I just say no actions. So it may be that, but remember, it's important if you're providing this evidence, please de-identify it. The surveyors don't need to know who this particular documentation applies to accordingly. Yes, you can provide a standard staff appraisal process, but the surveyor will say, yes, you've got a process, but can you show me that the discussions have taken place accordingly? So de-identify any HR documentation that you may have, because surveyors don't need to know that accordingly. When we're looking at information about the practice, which we spoke about earlier on, the website plays an important part. C1.1A indicator, our patients can access up-to-date information about the practice. Remember in the 4th edition, as I said earlier on today, it was all about a practice information sheet. And as we said in part A last week, not required now. And there's a number of ways you can promote accordingly. But you could use other evidence other than websites. You can still use your practice information sheet, which we spoke about previously accordingly. Well, there we are. We've done 3.2, accountability and responsibility. We're going to skip across to 3.5. We're going to leave 3.3 and 3.4. We'll give that a miss. And now we're going to work across to work health and safety, 3.5. Why is work health and safety in the standards so important? Because we're now talking about legal requirements now. We have a legal obligation to meet the respective adherence to federal and/or state workplace and health safety laws. We do know that there is now national laws, but Queensland is slightly different, and you need to look at what does this mean for you. Part of work health and safety, as I just indicated, we need to think about immunisation is the big part of C3.5 accordingly. We focus on emphasis on the value of practice team being immunised. It's about the testing of natural immunity to vaccine preventable disease for staff. And how do we work out what our immunisation requirements? Depends upon the risk of infection based upon a number of areas: practice location, patient demographics, and each team member's duty. So let's have a look at a deeper dive into 3.5 work health and safety. 3.5b says our practice team is encouraged, notice the word encouraged, to obtain immunisations recommended by the current edition of the AI handbook based on their duties and immunisation status. The you must in C3.5 that you have a recorded immunisation status of all patient teams. You notice the word a recorded immunisation status. And we'll come back to what this actually means, what that terminology means in a moment. This means having a record of what, with their consent, what the staff members have been immunised. So one way of meeting this is, can you please tell us what you have had? And in relation to this particular indicator, AGPAL in their registry of resources actually has a template that you can utilise for C3.5. If they have not been immunised, the record could be of the natural immunity, the lack of immunisation, or the refusal to give you this information. Let's look at the third dot point, the refusal to give information. If they refuse, it requires to be documented. That document that I just referred to, that template in AGPAL Registry Resources, actually has a refusal there. So there are three ways of meeting this indicator. Firstly, a staff member provides a list of immunisations that they're immunised against. Two, They can refuse to provide this information, and a consent has been provided for refusal. And the third one is they have provided you a natural immunity to vaccine preventable disease via a blood test. So there are your three options on this. So a surveyor will be looking for one of those three options in relation to meeting this particular indicator. Remember on this, it's important for you to understand that we encourage. So what we do and encourage, we may have a policy in relation to encouraging staff members to have these immunisations. Part of my induction program says you're entitled to, depending upon your role, if you're a nurse and you do all these things, Hep B, Hep A, mumps, or whatever it may be, accordingly, as what's indicated in the immunisation handbook, specific to the role accordingly. So remember in this one, please don't get hooked up to the extent that they must have immunisation identified. There are three ways, as I just said, on this from there to meet the respective criteria. Right. That's 3.5, work health and safety completed. Now let's look at, let's move forward now and look at, so that's standard 3 now. Let's move on to look at what standard 4 may look like, which is health promotion and activities. Righto. We're now going to go across and look at standard 6 accordingly. Now, in relation to 4 and 5, once again, we've skipped over those in relation to time component, and once again speak to Tanya at the PHN staff on what information you need on that, or speak to the CLO at AGPAL if you're an AGPAL client. But remember, I keep reiterating, please go back and look at the explanatory notes, which will provide you the information required, or once again, Accreditation Pro document, hover over the respective indicator and criterion, and they'll tell you what's required in relation to evidence to meet the intent. Has anyone got any questions in relation to immunisations accordingly, or position description statements or induction programs? If you have, just come off mute and ask the question, or just put it in your in the chat box accordingly before I move on to standard 6. Thanks, Nicole. Nothing from you, which is great. Righto. Let's look at core standard 6. The patient has an effective system for managing patient information. And there are 4 standards. Standard 1, patient identification. Standard 2, patient health record systems. Standard 3, confidentiality and privacy, which is an important one. And standard 4, information security. Now, the reason why information security is in managing patient information only because of the requirements of Privacy Act, as in standard 6, and the management of our IT system as well. So let's have a look at patient identification. We've been working with this now in the 4th edition. We're now moving in the 5th edition in relation to how to identify a patient. Why is this important? Well, verifying the patient's identity maintains patient safety and confidentiality. And it correctly identifies the patient. And we need to be mindful of identifying the correct patient, that the right patient is being dealt with at the right time and the right place. So we need to identify the patient. I know I haven't told you the story, but we had an issue a few years ago about this. The wrong patient was put into the appointment book at 9:15 in the morning because the receptionist knew the person who was calling in because they played soccer in the grand final the day before. And it all went pear-shaped from there. The patient wasn't identified by front desk. The patient wasn't identified by doctor. the wrong patient was up on the screen, the wrong medication was provided, the wrong shared health summary was uploaded, the chemist didn't identify. Thank goodness the patient checked their medication when they got home that night because she was allergic to penicillin, and the doctor had the wrong patient up the screen, which showed they weren't allergic to penicillin. So as you can see, patient identification is so important. So how do we meet this criteria? Well, we need to correct patient identification if and when necessary. That's why we need to ask the question. List what constitutes an approved patient identifiers. Can someone, while I'm talking, give me what may you use to identify a patient? So just to type in the box what may be used accordingly. Yeah, date of birth, thank you. Driver's license, continue on. Anyone else got any other questions? Medicare card, good one. The answer is no. Interesting thing. Notice the third dot point. Reason why a Medicare card is not considered an approved patient identifier as one of the three. There, we've got the date of birth, we've got the address, we've got the phone number, are generally the three which we use. A Medicare card and driver's license are not a form of, it's all right, Nicolette, is not used as a driver's license and or Medicare card, can be used as subsequent to find information. But legislation says that Medicare card is not a form of identifier because 110% of our population have a Medicare card. There are people out there with Medicare cards that use them for identification illegally. So the legislation says that Medicare card is not. You're in a hospital, for instance, or you're in a day surgical centre, and you're lying by the bed. They don't ask you for what's your Medicare number. They usually your name, your address, your phone number, your date of birth. So we need to understand the history of identifiers. They've come from the hospital system. This was a commission's request in the 4th edition that it goes into. So just remember, Medicare card is not. We've got to have protocols in place for asking patients for the 3 identifiers. Now, this is a really, really good validation process by the surveyor on this. Because what I do on this, we listen on the telephone. We're sitting in the waiting room. Are the 3 identifiers being asked by phone or the patient at the front desk? Whether on the phone or face-to-face. So this is why, this is one of the ones that we listen for. You may have a policy on this. It may be a new patient policy. It may be a booking in policy. So your indicator in this, what evidence do I need? Yeah, show me a policy accordingly. Some practices actually have a sign up near the computers. Please ask the patient these 3 questions. As what's happening now in relation to COVID, we're asking a series of questions as well. So I need some evidence on 6.1, mandatory A, in relation to 3 identifiers. And of course, some practices have now got signage up on their front desk saying, I'm required to ask you these 3 questions. Please don't get upset with me or yell at me or throw things at me accordingly. So it could be a signage up at the front desk as well. So that's patient identification, C6.1. The practice has a system for managing patient information. Let's have a look at C6.4. This is based around information security. The information security is such a large part of the standards, and it cuts across all the standards really accordingly. So why is it important? The explanatory notes say maintaining the privacy and security of patient information held by the practice is a legal obligation. This includes maintaining the security of computers and other devices within the practice. Now, let's talk about the information security around this. There's some interesting components to this. There is a document, the RACGP guidelines for information security in general practice, that is critical. You need to look at that document. Designated team member. You must have a designated team member who has the primary responsibility for the computer security. It is not your contractor. Your contractor does it for you, but someone needs to identify who that may be. Now, and what is the specifications of that role of the person who is doing it? Now, in relation to this, some practices do this a number of ways. They either identify it in the position description statement of the person, or B, they actually complete the business recovery plan, or what's called the CIS standards, the Computer Information Security Standards, downloadable from the college. Now, there's a checklist for each of one of those standards for the college. If I go on site and that checklist has been done by an external party, the next discussion I'm going to have with you at that point in time on information security is pretty easy, because I then know that someone has completed the business continuity plan in relation to recovery of data, etc. So if that initial document, the checklist, is completed and it is downloadable from that website there. But once again, this is identified in Accreditation Pro. You can click on the link and it'll download it for you. In that document, the plan will identify a whole range of things. Disaster recovery, backup, storage, restoration, who's going to do what, when it's got to be done, the timelines. It is all in a document completed by someone who has the responsibility in doing it. Now, my IT person completes that because they know there's more of the system about me, but at least it's completed by someone. In that document, it says who's responsible. It says me. Here are the things I'm responsible for. Here are the things other people are responsible for. Now, this particular document required to be completed for the 4th edition. If you had it for the 4th, it's okay for the 5th. But you need to be mindful of that. The first part you need to do is complete the CIS checklist. Part of the CIS checklist and the document talks about screensavers and how screensavers are to work. So you need to understand what screensavers, privacy protection tools such as screensavers, lockable screensavers. We also talk about if you've got mobile devices like laptops, like iPads, how are they managed in the practice? Do they have antivirus on them? What about your antivirus updates? What about your firewall updates? All these requirements for security, information security, are set out in the Computer Information Security Standards by the RACGP. And the surveyor will assess against those particular standards accordingly. But if you've done the checklist, I know I keep saying this, but it's really critical. If you've done the checklist against the 6 standards and the disaster recovery plan or the business continuity plan is completed, it's all okay. You'll meet it accordingly. Levels of access is also identified. Who has levels of access and why? It's about passwords, password access. So when we're looking at this, it's called the Business Continuity and Information Recovery Plan. I know it's a big part of the standards. It's a lot of work, but an external party who looks after your system can complete it quite easy. So the surveyors will need to see those documents, because that particular document goes across all our the standards of the college accordingly. I suppose when we're looking at information security as well, I need to see a current restoration of data. When did you do one last? Because it's quite common that backups don't work. And we think we're backing up, but are we backing up? So checking of backups in relation to data storage and restoration of data back onto your hard disk needs to be completed in accordance with the SIS requirements. Now, your IT person will have a policy around that, and your IT person can provide the surveyor with a summary of when the last update took place in relation to restoration accordingly from there. So C6.4 information security is a big part, and I mean a big part of the requirements for the standards. It's a big part which the surveyor will spend their time on. If the documentation is not there, we'll look hard at this. Part of information security, which we spoke about in Part A last week, is email and social media policy. If your practice uses email and social media, you must have a policy for their use. It's an interesting policy, this one. Even if you do not use email or social media, you must have a policy that says you do not use it. How unusual is this statement? Because this is not about you, this is about the patient. So when we go back to when we spoke about in Part A, about communicating to patients in relation to social media and email policy, you need to tell your patients we do not interact by email. That's our policy. Not using them is still a policy, and patients need to know that either on your website or on your practice information sheet or a sign which is up. The college actually has an information sheet on the use of email in social media in general practice that meets the criteria of C6.4, and it was written in conjunction with AVANT, the Medical Defence Organisation. Just an aside, you connect, which we discussed in Part A. There's nothing stopping you using social media, nothing stopping you using emails, but as long as there's a policy in place and information security is managed exceptionally well through firewalls and antivirus accordingly. In relation to this particular policy around email and social policy, staff need to be aware of what the risks may be associated with them. I explained to you, I don't know what I told you in Part A, that we had a breach last week whereby a new patient form was filled out. The email was transposed incorrectly. A referral was sent to this supposedly to the patient, but it was sent to another patient who ended up in America. She came back and said, well, this is not mine. And when you looked at it, there was a letter between her first name and last name, but you had to look 3 or 4 times to see that. So we've now gone to encryption using Adobe on documents which are being sent, and it can only be opened at the other end if they know the patient's date of birth. So it reduces it down accordingly. So it does actually happen. Information security also talks about appropriate procedures for storage, retention, and destruction of records. This is so important in relation to not only hard copies, but also hard disks. We have to ensure that there's a policy in place, and it will be in your business continuity plan, of how to dispose of hard disks, what your backup procedure is, and how you store information. So this should be available in your business continuity plan and information recovery plan accordingly. You notice we say here, test the backup. So we need to see some advice around the fact that backups were effectively taken place accordingly. So you can see in 6.4 that the big part of 6.4 is around IT. Can I just get some feedback from you all in relation to anyone, in relation to what, who manages your IT? Is it external or is it internal? Do you do it accordingly? I think this is important. Lisa, do you want to come off mute, Lisa, and tell us what you do in relation to your IT? you use yourself and an external provider. Has anyone, rather than sort of go by the chat box, I want to come off mute and talk to everyone in relation to whether they have completed the RACGP checklist accordingly, and how did you find it to use? Anyone want to sort of comment on the RACGP checklist accordingly? That's the key to C6.4 is the college standards, the CIS, not the 5th edition for general practice. They're a separate set of standards. They're the CIS, the Computer Information Security Standards. They're the ones that you need to meet because because it's linked in. This standard is linked in across all the other standards. It makes life a lot easier. As Suzanne said, they've got an internal tech now that manages it. It's interesting, isn't it? Just an aside on this is that how we've moved on now in relation to the standards. They are becoming more complicated in relation to the technical component of all. And as I said, I know what has to be done under the standards or information management, good information management governance, but can I do it? No, I'm not technically orientated on that. So when it's done internally, I look a little bit closer to see that all aspects of the C6.4 are met. So if you are doing this, make sure that your external provider or your internal provider is fully across what's requirement in relation to C6.4 accordingly. So that's Core 6, Information Management completed. So there we've done Core Standard 1, 2, 3, and 6 in the core module accordingly. So let's have a look at the key point summary before we start any questions, because we've got a bit of time for questions accordingly. Criterion 3.1, business management systems. This is quite important. This criteria focuses on having effective business management systems, as these systems impact upon your ability to provide and ensure patient care. This is about risk management. This is about goals and objectives. This is about, it can be around the 3 identifiers, although that's in C6.1. So business management systems are very critical to ensure that, that we deliver the service accordingly. So 3.1 is the aims and the goals. I come back and I'll say once again, it doesn't have to be a long detailed plan. A single page can meet the requirements, and make sure you update the documentation accordingly. So don't show me the one you may have put in for the previous cycle. Some people did it in 4. Please use a new one accordingly. The complexity of 3.1 will depend upon the complexity of your practice accordingly. Now let's have a look at accountability and responsibility, C3.2. This criterion focuses on the standard requirements and guides for managing and supporting your staff. Now, 3.2, performance indicators. I keep coming back here that there is a requirement, no requirement in relation to it must be formal. The college standards are not prescriptive on this. It's up to you how you manage performance discussions with each team member. But whichever approach that you take on this, it's important that you document the discussions and any actions which may take place accordingly. That particular document will form part of your evidence to meet this particular indicator. As I said, I also utilise on this my checklist for new staff members and for as part of the induction program, and the checklist for that 1 month, 2 month, 3 month review of new staff members, and the induction program and checklist for my registrars as well. So there's 2 or 3 other areas of evidence that I could use to meet the intent. Righto. There we have the presentation for today completed and all we've got left for now on what questions may be before we talk about Part C. Now, you've all been very good via the chat line today. I haven't had anyone come offline and say, "Hi, Gary, how are you today? Can I make a comment on something?" Any feedback at all? Anything, any further information you need in relation to today's presentation accordingly? From there, Tanya, have you got any verbal comments you want to make on this? No, no verbal comments.
Hi, Gary. How are you today?
I am fine. How are you? Thank goodness someone is out there. Oh God, I feel so lonely.
I didn't want you. Yeah, I thought you might be feeling lonely.
For 2 hours.
Yeah. We're
got...
here and listening, and thank you so much for that presentation. I don't personally have any questions,
yeah.
but
what's your role then, Tanya? What in relation to accreditation?
So you're talking to Nicolette.
Sorry.
Tanya's there too. Oh, there she is. Hello, Tanya.
Hi, sorry, I was just dealing with something on the email. Well, I work in digital health, so I do have a practice support background, so I'm definitely happy to help with any questions and sort of redirect and help where I can, you know, and work with you guys to facilitate that in practices if they need that help.
Tanya, the digital background is still important because that whole aspect of Facebook and the whole aspect of social media and emails are really important. You just may want to have a look at the college's policy around the use of email and social media, because they're quite critical for the accreditation process on that.
Yeah.
Who else was on this then that who was it?
Nicolette. She's also in our team.
Oh, Nicolette. All right. Thank you, Nicolette. Do you want to come back and make a comment, Nicolette?
I don't really have any comments. I'm sorry. But thank you. No, it's very interesting. It's very interesting indeed. And yeah, we you know, it's definitely things to think about. And I'm sorry, you know, for suggesting the Medicare card earlier.
No, that's fine. No,
it's good learning. It's good to kind of understand these things and some of the intricacies, because I think sometimes your mind does kind of jump to certain you know, evidence and things like that. So it's all these hints and tips are very handy to know, I'm sure.
The reason being, Nicolette, is that because it forms part of what we do. We always ask for a Medicare card.
Of course, yeah.
If I don't check the date, check the reference number, etc., etc. Otherwise, I'll get refused. So it's part of the mantra. It's a little bit like the driver's license. It's part of the mantra. Yeah. So it's a common mistake, and I reckon 95% of practices always chuck Medicare card into the mix, and you've got to go through the process and the reasons why from there as well. Thank you very much from that. Suzanne, you've made a couple of comments. Have you got any comments or thoughts on today? Anything which was clarified for you, or you need further clarification on, or from there?
No, I'm fine, Gary. That was a really nice presentation again.
Thanks, Suzanne. I appreciate your input.
It doesn't really matter if you're working for a small practice or a big practice. Once accreditation hits, we're all in the same boat. You know, I mean, I'm working for the Flying Doctors now, so I have a big team behind me to have.
Yes, you do have, Suzanne. Yes.
I'm just a small little number there, but it's still interesting to just refresh and see what the changes are and what I have to look out for as well in my team that I take care of, you know, on site in Cairns and the other locations.
Suzanne, thank you very much. I was at a Dubbo, the RFS, doing a pop in and just doing a look around Dubbo, and went to the RFS out there and had a look at their service as part of part of a tour. And the thing that struck me, Suzanne, is that your evidence which you would provide to substantiate the intent is completely different to what I would substantiate the intent.
Yeah.
Because of the nature of your service, you fly in, fly out sort of stuff, and your base is around Australia, or state by state it may be.
Yeah,
so,
that's right.
So you're a little bit like an AMS, Aboriginal Medical Service, that have different types of processes accordingly. So don't ever be afraid to step outside the box and say, oh, we can do this slightly different in relation to evidence-wise. And that's the nature of, and you're a classic example of the variance of the nature of a practice that's different from mainstream general practice accordingly.
Yeah.
Like transfer of patients, for instance, the clinical governance, you know, transferring of patients. How do I transfer patients? We have a completely different procedure than what I do when an ambulance turns up at our front door. Do you follow? You have a completely different process when you're transferring patients accordingly. So you think outside the box, don't think mainstream, because you have lots of evidence that you can show to meet the style and the complexity and the nature of your business. Good one.
Thank you, Gary.
Good. Anyone else? Anyone else want to make a comment before I move on to the next slide? No? Righto then. So what do we got now? What's coming up on part C? That's November the 11th, which is next week. We're going to be looking at the QI and GP modules next week. There are some new challenges and indicators in QI and GP, and we'll be looking at what may be some specific guidance on preparing some evidence around some of those indicators which are different. And I'm going to take you through a process, to me, which is the most important part of the accreditation visit, is the entry and the exit meetings, and what happens during an on-site accreditation accordingly. And I think that's important. As a matter of interest, I have a standard document that I actually send to practices as a surveyor a couple of weeks before I go, and it's sort of a checklist of what would be good for us all, and at the same time then how the day will work. And I think that's important for you practices to get understanding to de-stress you all in relation to how the day will work. And most of it, and we're all flexible. We're extremely flexible on how the day will work, because we're reflective in relation to your practice accordingly. If you need any support, please contact AGPAL accordingly. Your CLO will be more than happy to assist you from there accordingly. From there, and there will be evaluations taking place. PHN and AGPAL an evaluation will occur. Now, you got your workbooks, and today's slides were in that in the workbook accordingly from there. So thank you very, very much all. I wish you well. Have a great week, and we'll see you back next week and at your time at 9 o'clock on the on the 10th of November. Thanks very much for your time, everyone. Cheerio.